Well, welcome everybody. We're super excited to be doing this special live event. I'm Dr. Bustai, and I got Dr. Bolin on with me, and we're excited about bringing to you guys a discussion that will kind of give you a lot of the basis for making a decision about taking a board exam. Maybe you've already made that decision. Maybe you're sitting on the fence and you're not sure. Some of the issues related to board exams, the mindset that you have to have in order to tackle this beast that sometimes can be intimidating. And then obviously we want to give you some practical methods for success that have been proven over time. And we've been doing this for over a decade. And so we're just excited to bring this information to you guys. And so with that, we'll go ahead and get started. I do want to give a small disclaimer here that this is not being done in collaboration or with some sort of support with the Board of Pharmacy Specialties or any of the other board certification exams. It is being totally put on by High Yield Med Reviews, and it's not necessarily meant to be a commercial. So the information here is very relevant to you. If you're considering it or you're preparing for it or you've already started, and even if you're using some other product or service, it doesn't matter. All of this information here will be very helpful to you in making sure that you have the right mindset that will lead to success based on our experience, not only of taking these exams ourselves, but obviously having delivered it for over a decade. So I want to introduce ourselves to you. I'll start off first with my name is Dr. Bustai. For those of you that may not know me or I don't know you, we're excited to have all of you on. But my background is unique. I trained as a nurse, pharmacist, and a physician, and my current practice is in emergency medicine as a physician. I think that's important for you to know that I'm a frontline worker just like everybody else. I take care of patients, and I think it's important that as you're being taught by people and preparing for board exams, that those individuals are probably also taking care of patients and are involved or have enough experience to be able to provide that for you. And so I've been involved in nursing and pharmacy and medical academia for over 20 years, and I'm super excited to be here with you guys and share my experiences. I did take the BCPS exam back in the day, the year I graduated from residency. So I do have that practical experience. Dr. Boland, say hi to everybody and give a little brief background on you, and then we'll get started.
Good evening, everyone. So I'm Dr. Boland. I have a bit of a unique background, not quite as unique as Dr. Bustai, but mine's all in pharmacy. Let's put it that way. So the majority of my pharmacy career, I have been in academia for a decade and practicing in ambulatory care. But I've also spent time in community pharmacy, actually in the emergency department, which was kind of fun and interesting. And also as an inpatient clinical pharmacist and with antimicrobial stewardship. So I've been around the block a little bit, and it's good to be with you tonight.
Yeah, and you're not only BCACP certified, you also have the CDCES, which is an additional, level of certification. And so I think, it's nice to be able to have you, Dr. Boland, on with your background and unique experiences so that you guys that are all attending this, you're hearing from people that have been around, have done it, and have done more than one board exam. So I think that we speak with some level of credibility and practical experience. So what is the agenda for this evening? What is it that you're going to hear us discuss? And I think it's important that all aspects of it are considered, because you might go, oh, yeah, I don't need to know that, or I'm okay, I've made that decision. But there's actually some unique information that builds onto the purpose and structure for the exam and the mindset that you need to have. And the first is, if you're still at that level of struggling, should you even get board certified? And is it really worth it? Like some of you that made the decision, you might still be asking that question. Is this really worth my time and effort? Is it really worth all the money that I've spent and the pain and suffering that I'm kind of going through? Will re-motivate you. It is worth it. Why are the pass rates on many of these board exams actually pretty low? And I think this is one of the reasons why people are a little bit nervous. It creates anxiety, and they want to make sure that there's a return on investment. And so why is it so low? And is that a bad or good thing? I think it's actually a good thing. what is covered on the board exams? And this really gets into the mindset. You want to be playing the game. You are playing a game. You got to take a test. You have to answer multiple choice questions. And those questions come from a perspective that has to be valid according to standards of practice across the United States. And we're going to make sure that you, when you're studying, you focus on the right things, which may be slightly different than what you might expect from going to a national meeting and hearing a clinical practice review or an update or a CME program where you're hearing about the most cutting edge information. That is not necessarily the same type of information that is going to be on a board exam. So the mind game and mindset is very important. And then practically, how do you create a plan for success and succeed at this goal? Because it's a huge investment. Okay. You might be also going, well, okay, fine. I'm sold. I'm going to do this. I've made the commitment. But I need a help. I need some support, and I might rely on some notes, and I might rely on some trials and things. But I also may need a review course, and certainly we as a company provide that, and we will at the end offer you not only a perspective on our approach, so that if you need some help, given our years of doing this, but it quite honestly, a lot of this stuff in here doesn't matter what product you're using; it's still applicable. But we will share with you our model of success that we feel like we've had good success with and many people have done very well with, if that's something of value. And if you do want to move forward or you need a package or something like that, we're offering a coupon that we'll give to you at the end of this. And then we'll just stay on. We'll allow you to ask us questions. And if you want to submit a question, feel free to do that there on the webpage itself. And you can check if you want to be anonymous. We're not going to announce anybody's names, first names, last names, all those kind of things, unless you put it on there. But feel free to ask us questions, but give us a little bit of time to jump in because we might answer your question that you might have before you even get to the point of asking it. All right. So having said that, let's talk a little bit about some of the background and a little bit of the history, because I think it's somewhat relevant that if you look even in the literature, and I happen to be a little bit of a evidence-based medicine kind of junkie, I think it's important to know what the literature says and what are papers out there. And there have been a number of really big papers from well-respected pharmacists and people in leadership that have published papers on this. Does it really matter? Should we be doing this? And this has been published online through various resources, other journals. And so over the past 7 to 8 years, it seems that the wealth of sort of discussion has been ramping up. And when you look at that in the context of even like the BPS board certification and its history, which started all the way back in 1976, some of you on this probably weren't even, born yet. That dates me a little bit. But back then in 1978, they started out with the first board certification, which was in nuclear pharmacy. Just following that was pharmacotherapy and nutrition support. And it really stayed there for a number of years. And then after that, you saw this just, proliferation of different topics because, BCPS back in the day, people would get add-on qualifications and these types of things to, focus themselves in their area of expertise. But we all recognize that pharmacotherapy is pretty much everything, right? You're generalist about everything, kind of like internal medicine. And so it's evolved over the year with the most current one being emergency medicine. Okay. But what's next? So you got these 14 specialties, but what about all these other ones like neurology, gastroenterology, nephrology, toxicology, surgery? There's all these others, and we're starting to see the evolution, if you follow the history and the trends, that this is probably in the pipeline moving forward. There's a reason for this. Okay, and that reason is a good thing. And we'll, again, talk a little bit about that. How many people are certified and how has that shifted over the years? Okay, well, back in 2002, this is about the data that we had access to. There were 5,000 board certified pharmacists in the country. And if you look at how much they represented out of the total population of pharmacists, which around there were, about 224,000 licensed pharmacists, only made up 2%. So not a big, strong presence, most of those people predominantly being academia. But if you look over then each sort of 10-year period, 5 to 10 year period, you see this rapid growth that's starting to happen. So back in 2002 to 2010, over that 8-year period, there were approximately 7,000, certified pharmacists that were gained. That's about a little less than 1,000 per year. And then when you look at the next decade, then it bumped up to 3,800 pharmacists per year. And then, so now we're at this point where the percentage of total pharmacists that are board certified around 18%. And obviously the number of pharmacists have also increased with the number of schools that have increased and the expansion of the profession, the growing aging population. We're seeing growth. You're seeing movement. You're seeing a pattern here that says something important about what's happening within the profession. So what about observations as it relates to other professions? So right now, pharmacy is largely a voluntary process. If you want to get board certified, go do it, right? But no one's forcing it onto you. Now, certain practice environments, maybe career paths, like Dr. Boland and I, both in academia, it was sort of this expectation, right, Dr. Boland? I mean, I think that most people in academia tended to get a board certification. Is that your perspective at the academic institutions that you worked at?
Yeah, there was that expectation. I think you're starting to get more for the certification now than you probably were back
So,
then. It was more of a recommendation or
mhm.
a highly recommended
So you
credential
mean to
back
tell
then.
me
But I
you
think
didn't get
there's,
a massive raise when you got that board certification?
I did not. They paid
What?
for my exam.
Well, there you go. So it might not
There
be
you
a
go.
financial benefit at the moment, but I can tell you that we've interacted with directors of pharmacies of major hospital systems throughout the country. And now the expectation is even the pharmacist in an inpatient environment are all now being expected to get board certified. So it's moving in that direction. I know that the VA medical system, where I had an affiliation back in the day when I was in practicing clinical pharmacy, they actually gave you a raise for getting board certification. So the financial incentives are also starting to rise. But when you look at medicine, I mean, you won't get credentialed by a hospital or a insurance company unless you basically are board certified, and then you have to maintain it. That means that you're not just taking the board exams once and that's it, like in nursing and in pharmacy, but you've got to continue to take it. So even with BPS, they require recertification, and that's a good thing because it helps to keep you on top of your knowledge and continue to invest in lifelong learning. But it doesn't just end there, right? The other certifications are expected to be maintained, like ACLS and other things. Nurses have the same thing, especially those who are advanced practice nurses, like nurse anesthetists or midwives that would have prescriptive authority. Okay. So what are some of the reasons that people cite? If you were to read the literature, blogs and discussion boards about this topic, the most common cited reasons that are out there is that you're dedicated to lifelong learning and this thing called continuing education so that you stay up to date. And, this is important for helping you to set yourself apart in certain environments that you're going to be in. It certainly is now becoming more comparable to other healthcare professions, just like being modeled by what happens by physicians. Not that you're trying to become a physician, but the point of the matter is there's a similarity because that's what the public and that's what insurance and reimbursement agencies look at and know because of the history of the position. And then certainly peer recognition could be part of that. Maybe movements up a career ladder or maneuverability within the profession. So there's a lot of movement of pharmacy going into consulting and private business and entrepreneurship. And I think that's fantastic. I'm a reflection of that at some level. Okay. Having started this company, so there's other things that it does for you and will likely be warranted especially if you're trying to get some sort of reimbursement. And then lastly, the thing that we go into doing healthcare is to hopefully help people, improve public health, improve outcomes. But as I mentioned just a minute ago, there is now institutional issues and a little bit of pressure. So when you start looking at some of their accreditations, like JCO being a stroke center, being a heart center, and all these things, they're looking at not just the physicians and the capability or the technology of the facility, but they're looking at the whole team. Who's taking care of these people that are coming in, because we know, like for stroke, for example, that when you go to a stroke center, it's not just the physician, it's not just the presence of a neurologist, but it is also the nursing staff and the units that those patients go to that continue to maintain and manage those patients throughout their stroke to maximize the outcomes that they're benefiting from. And so I think that we're starting to see the movement and the forecast shifting in that direction. And certainly it's growing and it's picking up steam. And those are for obvious reasons. And I thought Dr. Haynes, who was just the past president of AACP and is a very well-known clinician in pharmacy and a leader. He summarized it very well in his article about this topic. And he says, yet we cannot ignore the expectations of patients and other healthcare professional colleagues. Board certifications will be increasingly important as the public demands are greater for accountability and the quality intensifies. So does board certification really matter? And in his opinion, he closed out the whole paper with, I would say the answer is a qualified yes. And I obviously agree. And you can see that he's dual credentialed, right? BCPS and BCACP. And a lot of clinicians do that, go that extra mile. So if you weren't hopefully encouraged or sold that maybe you weren't sure, you're sitting on the fence, now maybe you feel more confident that this is the path you want to go in. Those of you that dived in and started questioning yourself, it's worth it, okay? But you go, but why are these pass rates so awful? I mean, they are awful. They are not encouraging. I mean, no one goes into the test knowing that almost half of the people in that room are not going to pass. I mean, when you look down the history, so if you look on kind of the middle column there, you got 2021, the fall and the spring sessions, the percent pass rates for each of the individual BPS exams. If you look on the far right, that's 2020. If you go back to 2001 or 2002, when I took my BCPS exam, the BCPS statistics were actually at 52%. So, I mean, it's not changed a whole lot. And if you add up the average across all of those major, and these are probably the more common ones, you can see that 62 to 64% of people pass it. That means 38, almost 40% of people don't pass it. So that's not great, especially when you start looking at other exams. So let's just think about the NAPLEX itself. You remember that old test? Yeah, your favorite one. I mean, everybody had to take it to get licensed, right? But it was historically a minimal competency exam. Still relatively is, although they beefed it up a little bit, more clinical in nature. But the pass rate averages, well, this year it was lower. You know, does COVID, other things impact it? We don't know still. But it's been getting lower over time. Back in my day, I mean, the average is around 95, 96%. I mean, it was a joke almost, okay? But if you look at NCLEX RN, which is the nursing one, you see about 90%. When you look in medicine, like family medicine board exams or internal medicine, you see again at 90%. So is this a problem? I mean, why is pharmacy's performance low? Does it mean that something's wrong with the profession? I don't think so. I think all of you are very smart people, right? But the test has a different level of expectation. Is that bad or is that good? Well, I love this image. And for any of you that have ever been on another webinar where I talk about this, I keep coming back to the Olympics because there's no real other sort of great analogy than a gold medal in the Olympics. Because, I mean, how many people really get the opportunity to even go to the Olympics? Not many. And then the few who make it, how many actually walk away with a medal? Still not many. So when you get it, and these individuals represent, you know, people who won gold in their respective, areas or disciplines, and you can see that regardless of gender and race, doesn't matter, they're all expressing some level of emotion. And they're not crying because they're sad. They're crying because there's something that was obtained there. And it wasn't just the medal. I mean, medal is medal. It's what the medal means. What went into gaining that medal. So nothing of value, right? Nothing of value is ever going to come easy, right? It's just not. And if everybody could pass and everybody could win a gold medal, I mean, gold medals would mean nothing, right? And then you could go out in your backyard and dig in a hole and pick up some gold. No one would care. But the fact that you can't do that and get rich quickly and retire means that it has its value. Okay. And so these people were very, very purposeful. They made strategic, proactive, purposeful decisions to maximize their ability to succeed, because they know that they sometimes only have one chance. They're not like Michael Phelps. I mean, he's a rare individual to be able to go repeatedly over and over to the Olympics and win multiple medals like he did. So, okay, Dr. Bustai, that's great. It's hard, it's a value, but why is it still so hard? What is the issue that almost 40%, or even back in the day when you took it, that some of those scores were in the 50s? That means, again, almost half of people failed. So why is it so hard? And this goes back to what is being covered on a board exam. And I think when I talk about the mindset, and here's the bread and butter that you want to be paying attention to, because you have to separate yourself from what you sometimes see locally in your geographic practice, your biases of your clinicians, your own personal bias. And you have to separate yourself from a clinical practice review or a professional organization putting on a discussion panel of cutting edge information. That stuff, those subtle variations never make it to the board exam. And if you try to answer questions like you practice, you probably will miss questions. You have to think about what are the standards of practice that are well accepted and validated that apply to every clinician across the country, because you're not taking an exam for your state and your geographic region. You're taking an exam written for everybody, okay, in that particular specialty. So it's important that we think about what's on the exam. What type of knowledge are you having to focus on? Well, we always talk about this concept of knowledge transfer, and this is not something that High Yield made up. This is actually a published method, philosophy of understanding how people acquire knowledge. And if you just think about your own training in undergrad, your PharmD, and residency, it pretty much mimics this methodology of how people acquire and strengthen the depth of their knowledge. They go from the explicit knowledge, which is that fact-based kind of memorization of things, lisinopril is an ACE inhibitor. I mean, you just got to memorize that stuff. Then you got to move to the next level of, well, yeah, this is how ACE inhibitors work mechanistically. They block angiotensin converting enzymes. Well, yeah, but they also modify preload, afterload. Now you're starting to understand and mix physiology with it and pathophysiology. And then you got to go to the next level of applying it to a real patient. So if I give somebody too high of a dose of an ACE inhibitor who has bad aortic stenosis, I could make them pass out. That's the level of application that requires a drawing off of your explicit, tacit knowledge, but then building it to the application, which really is where true competency is. And this is another way of looking at that, right? We see knowledge or the things that we see on the surface. That's your explicit knowledge. But that depth, the stuff that's less tangible, the concepts of application, that's the kind of stuff that's being tested, because they want to see that you know how to apply it at a higher level than something like a NAPLEX exam. Does the NAPLEX content still apply to a BPS exam? Absolutely. It's just typically a little bit more of the explicit with some dabbling into the tacit knowledge, where BPS exams and CDCES and BCADM and all these other certifications are going, is they're trying to grab that tacit knowledge out of you and putting it on a multiple choice exam, assessing your ability to apply it at a much higher level. So they have to be established standards of practice. They cannot be things open to debate, being discussed, a certain level of disagreement. They're not good test questions. You're wasting your time. I don't know how else to say that. And the reason I bring it up and I'm stressing it is because we will commonly get emails from customers who are like, but. And I'm like, stop. You're on a rabbit trail in the wrong direction. That's great for clinical practice, but you're studying for a test, and that's a whole different thing here. Okay. Dr. Bolin, am I making this stuff up? I mean, you've
No,
taken,
you're not making up. You really do have to separate yourself from clinical practice, and I do definitely agree. If you go at the exam and you trend one way with the way you
yep.
practice, and you're reading questions and you're doing what you want to do, you are likely to miss something and make a mistake. But they're not trying to trick you. They're giving you information that is, standards of care, standards of practice. And so, one example of that kind of comes to mind that has become more well known, I guess, would be thinking about dosing the GLP-1s that come in pens that click. So in clinical practice, it's probably pretty well established in most places that do a lot of diabetes management that you can go in between the doses of medications like liraglutide or semaglutide. But that's not going to be on a board exam. If they're asking you, about
Mm.
ways that you can, manage some adverse effects or something like that's not going to be your answer. And if you're looking for that, you're going to miss it. Another thing is they're not going to bring out material like 2 weeks before your exam. Like for example, today they came out with a new study with tirzepatide, talking about the percent weight loss reduction. That's not well established practice. It's not even FDA approved. It's not even going to come close to your exam. So just a couple of examples to give you about how you can get stuck and really overwhelmed when you need to just kind of back up and
Yep.
go with the well-established knowledge.
Absolutely. And you, and even that approach and the mindset happens when you're starting to, your wheels are turning on the exam and you are starting to question yourself, step back. What is the core concept being likely asked here? Okay. Keep it simple. All right. So when we think about content, we also have to think about the blueprint, right? So this is an example of the BCPS exam. I just picked it because it's a common exam. Obviously, a lot of our customers take it, but obviously it's applicable to the other blueprints as well, published online. I'm not making this stuff up, but these are the major domains from BCPS, right? So you have pharmacotherapeutic decisions, which is pretty much the majority of the exam. Okay. And then you have 25% of the exam is things about literature evaluation and EBM, clinical research, and then practice management issues and health systems being 10%. Okay. Now, when you look at this blueprint, okay, but that still doesn't tell me what to focus on, because what are you not seeing in sometimes those descriptors? I mean, read it for yourself. You don't see what drug classes to focus on. You don't see what disease states, and then the next thing is, well, what guidelines do I need to focus on? And what in the guidelines, because a lot of people like to practice around the guidelines as if they are the absolutes to practice. And while they are good, important, they are guides. But let's just look at an example of guideline issues. All right, let's think about thyroid. There's more than one set of guidelines out there. You have the ATA and ACE. Okay, what about hyperdyslipidemia or hyperlipidemia? It's not just the joint collaborative one. ACE has their own, NLA has their own, ESC has their own. I mean, it doesn't, if you look at cross-inflammatory bowel, pain management, C. diff, you have more than one set of guidelines. And you may say, well, but everybody follows this one. Well, that's not true. I've been in practice long enough as a nurse, pharmacist, and physician to see that there are different angles and perspectives that not everybody follows or agrees. And you need to recognize that guidelines are always reflective of the committee at the time who put that set of guidelines together. And that's why it changes a lot. It has to do with the guideline committee's bias. So let's just take C. diff, because this one seems to have gotten a lot of attention. And everybody, I've had discussions, I can't tell you how many times with clinicians. Oh, we no longer use metronidazole for C. diff. We really should be only, the guidelines say to use vancomycin first line and fidaxomicin. Well, actually, that's not true. And if you stop and actually read it, it says on here fidaxomicin is the preferred over oral vancomycin. It says vancomycin here is an alternative. And then it goes on to say an alternative for non-severe CDI, if the other agents aren't available, is still metronidazole. Why do they say that? Well, if they dig a little bit deeper into the guidelines, you see that their recommendations also have a strength and level of evidence qualifier associated with it. So look at the recommendation for vancomycin. It says it's a strong recommendation. Okay, that's good. But wait a minute. It's based off of low quality evidence. That's a red flag. Because what's wrong with low quality evidence? Low quality evidence usually implies, under the principles of evidence-based medicine, that there is high risk for bias and there's question about the internal validity. If there's question about the strength and quality of the evidence and there's question about internal validity, there is a significant hindrance to external validity. Well, what do they say about number 2, fidaxomicin? Oh, it's a strong recommendation with moderate quality, which is probably why I got the preferred recommendation. But then if you look at number 6 there, it says, well, oral metronidazole, strong recommendation, moderate quality of evidence. And if you dig a little bit paper and actually read it, it says, given the above reported data, we believe all 3 agents have a role in first-line treatment of non-severe C. diff. Okay, so if fidaxomicin is the preferred and you want to be a guideline-driven person and a purist about it, based on low-quality data that is compromised internal validity, then you got to go, okay, so write the prescription for fidaxomicin. Recommend everybody to get fidaxomicin. Because if you go to the pharmacy and that patient doesn't have good insurance, the cost of fidaxomicin, $4,600. Oral vancomycin, $300. Metronidazole, $10. So you can write a recommendation to a patient all day long, but if your patient can't get the medication filled, it's useless. Okay, so part of this comes in is that guidelines are guides. They are not absolutes. And when you have more than one set of guidelines out there, or with recommendations that are not strong and have high quality evidence, it may not be the standard of practice for everybody across the country. Okay, that's important for you to know because they're not absolutes and they're open to change, which is every time the committee changes, you see that. And so does this matter? I mean, is it okay to have more than one recommendation or set of guidelines? I think it is. And the reason is because if you only had one set of guidelines, then you hear the bias of that committee. And you might not always get the other perspective. And so having 2 sets of guidelines, then what do? You look for the common theme. What are they both saying? What are they both advocating? Where are they on the same page? Okay. That's what drives you to, most likely, when they're in agreement, independent organizations, then they're most likely the standards of practice. Okay. And that's why it matters. Okay. Some of you may say, well, I want the ones that pharmacists focus on. I don't know any guidelines that are accepted national practice guidelines that are only written by pharmacists for pharmacists, that physicians will follow, nurses will follow. In fact, most guidelines are not even involving a pharmacist. Sad, but it's the truth. You'll see some nurses and you'll occasionally see one pharmacist, but it's not the norm. We all take care of the same disease. We all take care of the same patient, regardless of your area of specialty. So keep that in mind as you focus on it. And as you start to dig into guidelines, make sure you separate the minutia, the debated stuff out. That's great for everyday debates, but you're playing a game. Okay. Well, what about new information? Dr. Boland said that, gosh, I mean, she gave some excellent, really cutting edge information that would be, in my opinion, applicable to an exam at this level, but it has to be established. So if when you're looking at a content that goes on a board, you've got to write the questions. So the board, usually ask experts to contribute. They then have to get those questions back and do peer reviews and edits. They then have to turn around and validate the question, which means they've usually put it on an exam, and have it be tested in the real environment. So you will have some questions that will be on your test that may not count. They're being validated. Well, when you take all those things and then place them on an exam, especially when an exam is only being offered twice a year, you're looking at situations where you're only 6 to 12 months at minimum. So most of the time, concepts that are being tested are over 12 months old. Because even if it does come out, and even if it's robust information, it still takes time to permeate the system. I know that some guidelines came out and it takes months for them to be embraced or applied in a clinical environment. So nothing is usually overnight. Okay, so let's get down further into, now I know a little bit about what I should be focusing on and not focusing on. I get it, Dr. Bustai, Dr. Boland, you guys have made it clear to me. But now let's start to dive into the practical things that I can do, especially when I'm taking this test to pass. Well, again, we believe in evidence. We try to incorporate evidence-based medicine into our teaching because we believe that you should learn concepts in the proper context of the evidence. So when we can bring in evidence, we try to do that. And this was a published study, retrospective analysis, looking at people taking the BPS exams over a period of 2015 to 2018, 15,000 candidates. And they basically sub-stratified them based on their level of training. Those that just did practice only, they never did a residency, but they earned their time and they applied to sit for one of the board exams and qualified. Then there are those who do 1 or 2 year residencies, and then a cohort who did specialty residencies, basically a PGY2, assuming PGY1. And so what did they find? What was the sort of take home point? Well, those who did a residency training, more likely to pass. That's just what they found. Now, does that prove it? Well, it's a retrospective observational cohort study. So there's some limitations to that study design, but it's still helpful. And I would suggest that there's probably some truth to that. I know that I took the boards straight out of residency. If I talk to a resident, and if any of you on here are residents or fresh out of residency within your last year, take it as soon as possible. Do not wait. Your mind is still kind of in the framework of and being wired for learning. You're processing information. You've not gotten older, lazy, and starting drooling on yourself, right? Especially if you start having kids and dogs and bills and right? Your brain is shut off from that. Like I've done that for so many decades. I am done. Okay. So you start to get a little rusty and squeaky, right? The wheels, that's not a good mindset. And for those of you that have been out of residency or who never did a residency, you're like, oh, great. Well, that's it for me. I'm just giving up. Must I forget it? See it hanging up now. No, don't hang up. I'll tell you this. I had we had a customer, I think it was about a year and a half ago, 30 years out from graduation, 30, taking our review course. I was blown away. And the only reason she did it is because her boss basically at her hospital gave her no choice, right? So you can't just be grandfathered in, unfortunately, in all places. You can do it, but obviously the further you go out, what that means is you probably have picked up bad habits. You probably feel comfortable with the few drugs and things that you do day in and day out. That means what you're going to have to do, you're going to have to go back to some of the basics. You might have to re-review drugs, basic monitoring parameters, side effects, stuff like that, because that's that explicit knowledge, because things have emerged, changed, and they're not in your area. Okay. So our package, for example, high yield, we give people all of that information and you can decide at what level you need. We're not going to force it down your throat, because all of you come to us with different backgrounds, levels of training and experience. Okay. But being out of residency, really what's happened is during residency, you've been hit, and they've taken that tacit knowledge and they've really accelerated it. They say that 1 year of residency is equivalent to about 5 years of practice because you just do so much and you're put in so many unique environments where you're applying it at a higher level. So, regardless if I did a residency or not, okay, it depends on what bucket you're in. And all of you are probably in a different bucket. Okay. And some of you might be very comfortable and confident in yourself. That's great. You may not need much help. Some of you need more help. So what can you do to pass? Well, the first thing is failing to plan is a plan for failure. Period. End of discussion. I can tell you that none of those Olympians, 2 months, 6 months, a year before the Olympics decided, I think I'm just going to try out for the Olympics and I'm going to write a letter. I'm going to have my friend write a letter of recommendation and I should get in. No one. I mean, sometimes these kids started their training in utero, right? Parents, come on. You start breathing now. I'm joking, but they started early. Some of them at birth were starting to be, trained. And so when you look at these individuals, most of them have dedicated their entire life. They were homeschooled and did all kinds of other stuff because they were so committed to this agenda. And that's pretty much what you have to do to get to that point. So playing the game, get a plan and stick with it. I don't care what product you use. I mean, yeah, we'd love to have you as a customer, but the reality is you need to pick a product and use it like it's supposed to be used. Too many times I see people come and say, well, I used your stuff and I didn't pass. And then we go, oh, well, what are your statistics? Oh, we see that you only answered 10% of the questions. Oh, you only watched 10 or 15% of the lectures. Well, you didn't use anything, right? You have to do your part, but go with the program and the plans that are put out by that product or service, okay? The next thing that I'd like to say is reading versus answering a question, which I'm going to talk about next. Avoiding the mind trap, which happens to a lot of people. They start talking themselves out of answers. And then we'll cover some test taking strategies. What do I mean by reading versus answering? Well, when you think about this, you're reading a test question. So if you don't have access to a QBank and you think you're just going to sit there and listen to lectures or go to some review course and have somebody lecture at you, for hours at a time, and you're going to walk out and then take the exam and pass, you're not. You're in that bucket of people failing. You are taking a real exam with multiple choice questions. So you have to practice doing that. You're not going to go out and run a marathon or a triathlon and you don't run. It ain't going to happen. You probably won't make it. Just being honest, right? But no one would think that's reasonable, is it? So the same thing is here. So when you're playing the game, especially when you start reading the question, what happens is they sometimes put distracting information in there versus information that have keywords where they're trying to give you literally a pattern of association. Okay, no different than real world clinical practice. As you're listening to the HPI or you're talking to the patient, you're hearing things and keywords and you're seeing a pattern. And that should be telling you a story. Why are you here? What is your problem? Why are you not at your goal? Why are you not compliant? So let's look at a sample test question and I'll show you what I mean. So this is a 49-year-old male, past medical history, AFib, heart failure with reduced ejection fraction, hypertension, hyperlipidemia, arthritis, comes into the clinic with an area of redness to the right lower extremity after a mechanical fall 2 days ago. Current medications, lisinopril, metoprolol, HCTC, simvastatin, warfarin. Okay, moving on. Oh, he's found to have cellulitis without an abscess. Okay. Excuse me. He is unsure when his last tetanus shot was. That's somewhat relevant, right? Fell, scratched himself, got an injury. I'm supposed to think about that. He has an allergy to tetracyclines. Is that relevant? He started to take Bactrim with Keflex. That's what the provider gave for the cellulitis. 2 days later, comes back saying, hey, yo, man, my pee is like turning brown. What's up with that? Right? So which of the following explains this situation? So you should be looking for keywords, looking for a pattern. What's the first red flag that should always jump to your mind? Rat poison. When you see rat poison in a question, it's a problem. Period. In a discussion, it's a problem. They're probably trying to tell you something. right? Even if you don't like it. And I hate the drug, right? Plagued by PTSD from my anticoagulation clinic days, right? Dr. Boland, I know I probably struck a chord with you. But then the next one is Bactrim, right? Because Bactrim is also known to be problematic. You start antibiotics, C. diff, drug interactions. We know Bactrim has a very unique metabolic profile that can inhibit the metabolism of warfarin. We know warfarin causes all kinds or is associated with all kinds of drug interactions. But then what's up with the dark colored tea, urine? I mean, what's up with that? I mean, is that just like some, it's relevant, right? They're not here for their heart failure. They're not here for their hypertension like you want it to be. They're here about cellulitis. This is an infectious disease question that has evolved into a drug interaction question. So really the concept is, can you recognize the drug interaction? And what's happening with the tea colored urine? Basically, they're over anticoagulated because the coumadin is being elevated because it's being inhibited by the Bactrim. So Bactrim inhibits 2C9, which inhibits the S isomer of warfarin. So that's explicit knowledge with some level of tacit integration now being applied here clinically at a level where you are applying it at a higher level of competency. So why would you pick rhabdomyolysis? Some of you probably picked it. Because what did you see? Simvastatin, another red flag. And you automatically assumed rhabdomyolysis. Why would somebody pick new onset cystitis with hematuria? Because their urine can look like dark colored tea, because that's what hematuria looks like. But did you hear frequency of urination? Did you hear dysuria? Did you hear costophrenic angle? Was there any of that pattern of association anywhere in the question? No. So UTIs don't sound like the right path. What about post-streptococcal glomerulonephritis? Who gets that? Post-strep, strep pharyngitis. Did this patient have any complaints of sore throat? Did they get tested with the rapid strep test? No, 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 no. So there's a pattern of association that really what they're asking for is, do you know the drug interaction and can you recognize it? Period. Okay. So read and answer the question. Look for the pattern. Sometimes all that stuff is distraction. So avoid the mind trap. Sometimes we get stressed. Why are they asking this kind of stuff? Because in the real world, for people that are board certified, you are probably at a higher level of practice. You're doing this for a reason. You've got to be able to think sometimes in stressful situations. I remember after getting medical school and going to residency, I was terrified, even with my background in pharmacy and nursing. I was scared that I was going to make a mistake. Now I'm going to try to pull all this in. And when you're responsible for the patient, ultimately, and if I call out an order and it's done, I'm like, is that the right dose? I need to look it up. It makes you nervous if you care, right? So they want to make sure that you can mentally adjust, like in the Olympics. Can you separate out all of these distractions? Can you focus? Can you make good decisions under pressure? If you start getting chest pain, nauseous, diaphoretic in the test, breathe. And then say, what does Dr. Bust-Eye tell me to do? Hopefully you don't start talking out loud and start hallucinating and have, I'm just kidding. But, you don't fall into the trap. Ask yourself, stop. What is the core concept? What are the distractions? Is there a pattern of association? This has to be the standard of practice. What are they most likely trying to get me to see? Sometimes you can predict the question before you read the question. Okay. So the answer and the pattern and the keywords are there, no different than they were there in that question that I showed you. And if you find yourself coming down to two answers and you're like, both of these are correct, and I'm mad and I'm going to write, I'm going to tell them. Okay. Well, unfortunately, you might be able to tell them and you might be able to argue your points, but there probably is a better answer of the two. So if you find yourself going, I have no idea which one of these to pick, then here's what you do. You say a small 2-second prayer, and we're going to practice this right now. Okay, you ready? 2 seconds. Dear God, 1 second, help me. Dear God, help me. Now you can say it out loud, but you might heads turning in the room. But it's a 2-second prayer. Dear God, help me. Click, save, and move on. Let it go. Let it go. Isn't there a song called Let It Go? Let it go. Okay? I won't go any further than that. I'm not going to sing to you. So you, as you can see, we
Please
like to
sing.
dear God, you do not want me to sing. Okay. So play to win. Okay. Prepare appropriately. Put a plan into place, recognizing that you're not, doing a CE program. Focus on high yield, established core concepts. Look for those patterns of association. And remember, you're looking for questions that are accepted by everybody across the spectrum of practice. The other things that you can do on the day of or right around the exam is get out there and exercise. Get the blood flow going to that noggin. Okay? Your GI tract isn't going to help you during the exam to cognitively pull out information. So don't eat a high carb meal, okay, with a bunch of sugar. Don't stop at what's the donut place? Not Shipley's. The other
Dunkin'
famous.
Donuts.
Oh, Dunkin' Donuts is another good one, but it's missing. I'm slipped my mind. The one that you comes right off the
Krispy
hot.
Kreme.
Oh, there it is,
Krispy
Krispy Kreme.
Kreme.
Do not stop at Krispy Kreme on the way to take your test. You will have postprandial fatigue at its greatest when your brain needs all of the blood flow. Okay, so we don't need brain steel. We need complex carbohydrates like fruits and vegetables. Okay, quality proteins with low fat. Okay, not so much fat that you have to have all this blood flow and utilize all your gastric enzymes to digest this stuff. Okay, so you go into the fed state. Good proteins that give you the energy you need. Do not drink a gallon of water before you go in, because you might be walking up to the proctor saying, I've got, and if you have kids, you might be saying stuff like, I've got to go TT. Or if you're single and you don't, you might say, I've got to micturate. Okay. Don't make yourself have to go to the bathroom. It's a distraction. Okay. You want to be adequately hydrated, but you don't want to be excessive and answer all the questions. No one gets credit for leaving something blank. Do not do that. Okay. All right. Bust-Eye, I'm convinced. Boland, I'm convinced. I'm ready to go, but I need a product. Okay. Well, I can't speak for all the other products out there. I mean, I know of who they are. Okay. And I'm not going to say anything negative. They're good people. It's a different plan. But if you need something that we can help you with, let me explain to you why we think we are successful and offer a pass guarantee that nobody else does. Okay. Again, this is not meant to be a commercial. It's just the fact. We stand behind it because the model works if you do it. Okay. So what does that look like? Why should I pick you, high yields, over some other place that's been around for a lot longer than you? What makes you so special or different? I mean, we've actually been asked that question, and there's truth to that. Okay. So we use a philosophy, and we use this infographic to basically say this is the high yield approach. There's something called learn, practice, apply, and then let's review. That is the stepwise progression that you make in going through content. What is learn? That's going back to a lot of that explicit knowledge and certain tacit level knowledge of discussions. Okay, your lectures, your ebooks, and your printed book material that you're reviewing. Number 2, you have to apply. Start practicing implementing those core concepts through practice test questions. That means you need a Q bank. Remember, you are taking a multiple choice exam. Lastly, we start to take you to that next level of application by going over cases. And our case-based reviews also happen to have CE associated with it. So if you need licensure renewal CE, I mean, you're studying anyway, you might as well get CE for it. And then lastly, right before you go in, let's review. Well, how does that apply going back to knowledge transfer? Well, explicit knowledge is that lecture. Your tacit knowledge is trying to get you into that application of the core concepts. And then that clinical application is where we really pull it together in the case-based reviews. Those are the funnest, in my opinion, because it's really where it comes alive, where the light bulb sort of goes off and you go, I get it. And that's where you understand it. And then everybody needs to make sure they brush off the dust a little bit right before they walk into the exam. And so when you think about this and you go, okay, but Bust-I, how do you practically do that? How much time do I need? Okay. You know, some people say I have 1 month, 3 months, 6 months, 12 months, and we sell all those durations because people are different. Everybody's got a different mindset, plan, goals, background. We get it. But if you look at the majority of discussion boards and papers that are kind of written on this, they say at least 3 months. I mean, look, almost 40, sometimes almost 50% of people fail for a reason. They fail for a reason. So we advise at minimum 3 to 6 months. That's why we're putting this on for you, because really, if you're taking the fall exams, you should be started now. You need a 5-6 month window to start now to do that, okay? Or you need 12 months so that you can prepare for the spring exams. That's why we're doing this. The applications open up here very soon for you to sit for the exams. So you need to make decisions. So, but what does that practically look like, the learn, practice, apply? Well, you take a topic area, cardiology, infectious disease, whatever it is, we collate the information in those, in QBank and in lectures. And then we do case-based reviews that integrate those topic areas. And you get CE for it. You do that, learn, practice, apply. So you'll listen to lectures, you'll practice your questions in QBank, you'll join us on the case-based discussions to integrate it all and apply it and get CE for it all at the same time. You do that for each of the topics over all the topic areas. And it depends on which exam you're needing to study for. But you do that repeatedly for each group. Listen to lectures, practice test questions in that area, join the case-based reviews, and then get your CE. Come towards the end, you got that last 1 to 2 weeks, we do rapid reviews. Rapid reviews are not meant to be primary teaching. It's to brush off that dust, make sure you got the key concepts that definitely are foolproof. You go back to your QBank because in our QBank, you can flag a question to go back to it. You come and join sessions where we're online like this, where you have access to faculty beyond not just Cassie and I, but also Dr. Kokio and other experts. We have other contributors that come in, and we open it up for you to ask us any question you want. It's basically like free tutoring, part of your package. We just do that to help you as an investment. And we even allow some of the people from other programs to come and get help if they need it. Because we realize, we've all been there, that sometimes not everybody has access to a study group. But when you're all done with this, you take the test and you're going to pass. And we offer 100% pass guarantee. Now, what does that mean? You'll get your money back if you fail, if you do your part. I'm not going to give you money back for something that you didn't finish. And you can't blame us for failing if you didn't do your part. But if you follow the plan, systematically, purposeful plan, you will make it through the content. And not just the things that you like to do, but everything that you need to pass. So now what? Join the race. Get your tools, whatever product, service you want. Recognize what the plan is. Raise your arms up like Usain Bolt there. He's the man in control. And then you got to start. But I'm not just talking about start and start slow. Start strong and run hard. Why is it? Look, I mean, this is how Usain Bolt wins races. Look where he's at compared to everybody else. His foot is still in the air. I mean, he timed his launch that perfect. Well, of course he won, right? I mean, that's most people that know this have ever seen the Olympics, especially watching him race. He usually wins. And he doesn't just kind of win. He like blows people out of the water, win. And that's what you want to do. You don't want to just prepare for the test and go into the exam, oh, squeaking by, especially on an exam where the average historically is in the low 60s. You want to join a group or people that are going to stand around and support you and give you the tools that you need, put you on the right path, get you launched from the pad strong, and finish the race ahead of everybody else. I'd rather give you wiggle room and have you miss questions that, just because we can't cover everything under the sun, and have you still pass. There are a few questions. Let's see. Took the test this weekend. Oh, you must be taking it. You're on this, but you've already taken it. I see. Had a ton of practice, process, communications, principles of education. Yep, agreed. But if you follow the blueprint, when people say that stuff to me, they have a lot of those. It can't be more than the percentage of the domain. And if it is, then they designed their test wrong. They violated or were deceptive about what the test was going to be organized around. That's why I cover the blueprint. Look at the percent. It may feel like you see a certain amount, and it may feel like those questions, but the percentage should not have been above that domain specific percentage. Okay. The other thing is, do we have practice management questions? And the answer is yes. I think there's like 100 of them. And where do we get that from? Some of you might ask that. Well, we take the ASHP best practices in pharmacy practice because we figure that those are the standards. I mean, ASHP pretty much will write the standards for a lot of things. We looked at ACCP, APHA, these kind of other things, and picked on those things that are more common. How can I have access to the BCOP rapid review? It should be, if you're a customer of ours, it's on your dashboard, and the session for BCOP, I think, is labeled. We had 2 clinical pharmacists, oncology pharmacists from the University of Kentucky, Dr. Allison Butts and Dr. Beth Travers, who were rock stars and covered some of that. If it's more in-depth BOCP content, at the moment, we are working on recording some of those lectures for some of the disease states and drug class reviews for that exam. But there is a book or a rapid review book of content that can help you with that is associated with your package. So it's a part of your package. So here's another one. For the BCACP, okay, Dr. Bolin, get your antenna up. I see lectures for kinetics. Can I expect to see much of that on the exam? Well, let me make a comment before Dr. Bolin jumps in here. The reason that we cover pharmacokinetics is that it's the foundation for everything, whether you think it is or you think you're using it or not. If you don't understand pharmacokinetic and dynamic principles, the rest of it doesn't make sense. You might not fully connect the dots like that, but that's the truth. That's my opinion. Dr. Bolin, since I biased you significantly, say what you want to say.
I'm not going to comment from the perspective of like remembering what, was on the exam that I took or the recertification exam that I took. But I will agree that that there are concepts there that could help you and help you understand the other content, and help you actually learn it versus memorize it, which can make a big difference.
Absolutely. Let me just give you a quick relevant example, two examples. Well, let's just assume that your patient, I gave the example of otitis media. If your patient comes in with otitis media, which I see quite often, and they are nauseous and vomiting because the pressure in their ear is so great, they're becoming vertiginous, vertigo, basically, and they vomit. Are you going to hand them an oral antibiotic to take so they throw it up? No. Pharmacokinetically, you're going to consider dosage formulations that bypass the GI tract and that would maximize bioavailability, i.e. then delivery to the problem, and ensure that the problem is dealt with. So what can I give in that scenario? based on pharmacokinetics dosage formulations. Ceftriaxone injection covers them for 24 hours, guaranteed that kid or that patient is covered. And usually in that first 24 hours, they will improve after that shot. And I will write them a prescription, but I also tell them, if you can't hold this down, then come back. But most of the time, they are fine after that first 24 hours. Let me give you example number 2. Let's do it to the acute care environment. What if somebody comes in and having a STEMI, ST segment elevation MI? One of the standards of practice, whether you do it or not, is Lovenox. Lovenox, or enoxaparin, is FDA approved to be given as a 30 milligram IV push dose. Well, if you think about the kinetics, why would you do that? Because you need immediate anticoagulation, and giving it subcutaneously delays the peak by an hour. So giving it IV push removes the pharmacokinetics of enoxaparin and does the same exact thing as unfractionated heparin. Drips, essentially. But those principles and understanding the application of how that works and why you do it like that is all based on pharmacokinetic understanding. If you want to go to Dr. Boland's world and the ambulatory care clinic and you put somebody on a basal insulin, what are you doing with that? Physiologically, you're creating a steady state concentration. You're not creating peaks and valleys, Cmax, Cmins that look like this. That's not going to do your patient any good. We don't use extended release products because we want peaks and valleys. So pharmacokinetics, you obviously hear my bias, my opinion. Yes, are they going to, on BCACP, are they going to ask you, what is the oral bioavailability of this drug? No. But the concept of understanding the principle as it applies to a higher level of application, you can't answer that question appropriately if you don't have some of that basis. All right, next question
and
is.
I will add, sorry, I was just going to add in thinking about that, you might be sitting here thinking, well, but I know that's common sense to me. But if you are asked a question that's outside your normal everyday comfort of your practice, then those kinetics might be a little bit rusty and those choices may not be as intuitive to you. And that goes back to talking about the pass rates being so low.
Yep.
And I think another reason that is because sometimes we're like, I'm a great, I'm not speaking about me. I'm just giving you an example. I'm a great ambulatory care pharmacist, or I'm a great inpatient pharmacist. I'm just going to go in and sit for this exam. And I think that is a huge mistake, just because they are not just going to test you on diabetes or osteoporosis, or if you're going, BPS or BCPS, they're not just going to test you on ID. They're going to test you on all of it.
Yep.
So you've got to be sure you study for all of it.
Absolutely. Those of you that are taking some of the specialty exams too, in particular like BCIDP, just so you know, on our side, we have added a bunch of information in there about antimicrobial stewardship because we've received feedback that that's something that you guys needed. And it makes sense. So there's a whole antimicrobial stewardship series. And Dr. Boland was also a participant in that because of her experience on the antimicrobial stewardship service prior to her going into ambulatory care practice, in addition to other people that do that as well. Questions were added. We've upgraded, for this BCOP people. I mean, we have a whole group. Those questions are only written by BCOP credentialed people with active credentials, period. And we have to replace those and try to update those questions every 6 to 12 months because it turns faster than other ones. So we are working on some of those, areas to strengthen them even further and further based on feedback and based on people's needs. And everybody's needs are a little bit different, but we welcome your feedback too. Do you have to get BPS before BCGP? I'm not sure. I think, are you referring to the fact that do you have to get BCPS? And if that's your question, the answer is no. You sit for the exam that you qualify for. That's what you. That's what the board BPS is going to be assessing is this an appropriate exam for you to sit for? So if you're let's say you're an ambulatory care pharmacist, you sitting for the critical care exam doesn't make sense, right? So, they're going to ask you, why are you taking this, or why are you petitioning to take this exam? And I think that is in part, vetting it out. And you probably won't do well unless that's an area of interest. Now, that doesn't mean that somebody from ambulatory care can't go to critical care. It's just going to be a shift. Okay, well, it's been fun being with you guys. I hope that you found this to be useful. If there's anything that we can do to be of service to you or your colleagues, or you're in a study group and you guys need help, or we offer group discounts, those kind of things, just reach out to us. If you also find yourself in a situation where your plans change, because life just comes up, and we all set up a plan, and sometimes it doesn't always work out like we want it to, it's okay. Reach out to us. If you need to extend, or you need an option to renew at a rate, we're here to help you. Yes, we have to stay afloat as a company. So yes, at some level we have to make some money. That's true of anything, right? But the reality is we are trying to partner with you in your success, because if we do that with more people, you're going to go out and help more people and provide a higher quality of care. That's our opinion. And then from a mission standpoint, we then impact the public health at a much higher level than we can do individually on our own. So please do not ever be afraid to email, ask us. Our customer service folks are amazing individuals. They will take care of you like nobody else. Okay. Okay. With that, we're going to let you guys go. Take care.